game plan now that if we have to staff those areas back up or extend hours for some of those things, we're at a much better position than we were in the spring to do so.
Awesome. So I think everybody, all three panelists have mentioned, the staffing shortages, the equipment shortages, the decreased volumes and reimbursement. So thinking about all of those things in this environment, what measures are you taking to control the costs associated with the, the expenditures that you're having to make by maybe paying more money for equipment on eBay or having to pay out the bonuses in order to retain nursing staff? How about we start with you on this one, Paul? What sort of measures are you adopting as a system to kind of contain the cost?
I'm not particularly proud of this, but it's something we had to do. We did not do employee raises this year. I think a lot of health systems did the same thing, just because we knew where we were going cost-wise. I wish I could say we had taken drastic measures, that there's just not a whole lot to be done really quickly. We actually had to add considerable staff for screeners and patient flow help in our physician practices. We're doing all the things we would normally do to control costs, but other than not doing raises, that's about it. And we've actually had to do some market increases just to retain people. When one hospital makes a market increase, we all have to do it. We've had to do that. I guess I wouldn't say it's a good thing, but right now the expectations of the board are fairly low financially. It's a matter of treating the patients and doing it well is the most important thing.
I would say for Mon Health System, just being able to quickly mobilize to be able to identify all the associated increase in costs was a challenge in the very beginning. We were able to do that fairly quickly, and we were in a position to where when the state shut down all elective procedures, we did have some accounts receivable that we could squeeze on. Everybody's always got accounts receivable that you can squeeze on. I don't care how tight your shops are run, right? We were very fortunate that we were able to squeeze our accounts receivable and liquidate some assets that we were able to do that at a level to where we could cover all of our operating costs through the downturn. We didn't have to do furloughs. We didn't have to cut into benefits. We do still have a cost of living increase that is going in this fall. I'll tell you on what further complicated our COVID response is that in August we converted systems. So we had a Big Bang Theory EHR conversion that kicked off August 1st. And so normally you squeeze on that AR so that you have a cash cushion through the first 6 months of your conversion, right? So that option was kind of taken off the table because we had already squeezed every bit that we could out in response to COVID. So we are, like Paul mentioned, I think that our board's expectation for financial performance right now is thankfully aligned with where our current situation is. And we did participate with a lot of the CARES Act funding. We did accept the advanced Medicare payments, and we are, with the new system conversion, we are capturing more revenues. But as everyone who's lived through a conversion or two know, it takes a little while for that to convert to cash. So that's our current situation between COVID and the conversion. We're tight, and I don't know that there's much that we can do to control the expenses. The expenses are what they are right now. We aren't spending frivolously, but they are higher on a monthly basis, just given the circumstance.
We had a similar situation at Regional Medical Center. We chose not to furlough any employees because we felt like during this difficult time, it was not the prudent thing to do it to hurt our employees who were already hurting. Also, we had a shortage of staff. And again, as everybody else said, you really needed more staff to staff the tents and other things. So just like everybody else, we also were struggling. CARES Act funding did help, and South Carolina really did a great job of providing fundings. They also provided funding for testing, and we had a lot of community testing sites, and sometimes twice a week, so that we could do a lot of community testing. So fortunately, we got paid for those testing, and that was helpful because it was a cost. But we just kind of made sure that we account for all the expense related to CARES Act or expense related to COVID, because that was really critical to ensure that we can support during the audit. So, but just like everybody else, it's been a tough time. And again, the board expectation has been aligned with the current situation. So that was kind of great.
So you all have talked about, the clinical staff and needing to spend more money on the clinical staff and, some raises related to that and bonuses and things like that. But I haven't heard you mention, the revenue cycle staff, the back end staff, the staff that's, keeping the bills going out the door. And maybe in a situation like this is the staff that's easier to consider furloughing or laying off because they're not providing the care. However, I think everyone on this panel and in this audience would agree that they are a valuable part of the cycle. And, if we can't get the bills out the door after we provide the care, then we can't keep the lights on, and the circle kind of continues. So, maybe starting with you this time, Candy, can you speak specifically to how you've handled the revenue cycle staff? Have you had to furlough them? Have you brought them back? Are you leaning more on outside vendors? Kind of how are you handling that piece of the puzzle during this pandemic?
So as I stated before, our experience is twofold. It's COVID and it's system conversion at the same time. So when we had to suspend doing elective procedures, I went to the board and to my fellow executives and said, look, I know that we have to low census clinical staff right now because we're not performing as many services. However, I respectfully request that we do not low census anyone from a billing, coding, follow-up perspective. Within revenue cycle, our pre-access service center, obviously those folks, they shared hours anywhere across the system where we had to low census people. Everyone took a little bit of a hit so that it was shared. The exception to that would be in billing and coding, and we did not low census anyone. In fact, we opened up overtime opportunities as long as the cash was coming in and we were able to liquidate those assets. It was all hands on deck. Everybody do everything that they can to make sure that we could sustain and cover our operating costs month over month during the crises. We also sent everyone home with the exception of those folks that remained in the call center over the course of about a 3-day period. We did that without a telecommuting agreement in place. West Virginia is kind of a unique environment. I'm sure that both of you have that as well in Tennessee, where there are some rural areas where there is no connectivity. There is not a fast enough internet connection for folks to work from home. But we were able to accommodate those who could and send them home within 3 days. It worked out well. But when we approached conversion, just as our revenues were returning in June and July, we also were training for the new system, and we needed to bring folks back into the offices until we could stabilize post-conversion. So we currently have a blend. There are some areas that have stabilized, and we've been able to send those folks back home. But for the most part, we have a pretty full house right now with everybody back. We didn't do any furloughs in coding and billing. The other areas that were impacted due to volumes were low census, but they did share that load. And there were risks associated with that. We knew that up front. We did have a significant portion of our staff at one point on quarantine due to exposures outside of the health system. So that's also another facet of this that I'm sure that everybody is also managing. We have a really conservative quarantine policy. So if you are exposed to someone who has a positive test result, you're quarantined for 14 days and you have to have a negative result to come back. So that did impact our business units. We had about half of our pre-access service center staff out 3 days before conversion. Yeah, and we didn't get them back for 14 days. Some of them we didn't get back for a month. So we have had to augment with some external labor We have now farmed out the rest of our AR legacy to a partner. And so they're working that down for us there while we're squeezing the new AR and the new system. So lots of things were done, but those are kind of the highlights.
I think for us, we were in a similar situation. We did not reduce any hours for registration, patient billing, coding, and because we wanted to make sure that we had adequate resources and get all the cash we can, just like Candy had mentioned. The other thing which we did was we also partner with some new vendors. We brought in some new vendors to help us in collection of patient financing and those type of things. So that was really helpful. Our revenue cycle was a little bit challenged anyhow, so we really need to bring in some new vendors, and we got some new resources added. We brought in a new AVP of revenue cycle, and so we did a lot of things to make sure that the revenue cycle was not impacted. And just like Candy, at one time I had half my accounting staff out during the month-end close because their family members had COVID positive, and so again they were out 14 days, and it was very difficult to close the books during month end when you have the staff is not there, and they're also having challenges with technology, even though we send the computers to their houses and everything. But one of them was using their cell phone wireless to access, and again that was very slow. And so anyhow, we all kind of went through a real major challenge, but our focus was to make sure that revenue cycle was not impacted in any way, because at the end of the day, that's the most critical thing, other than taking care of patients and that type of thing. The other thing we didn't do was we didn't let people work from home because we were not sure how would we monitor that. And fortunately, that worked well for us. And so we just kind of decided that everybody who works is essential. So we really didn't have a lot of telecommuting type opportunity.
Yeah, we did things a little differently, and we did have to furlough people. I should have said that earlier. More than half of our business is elective surgery. We're very big in orthopedics. So, I mean, pre-service, there wasn't a need for pre-service. And, in the first months, our gross revenue was half of its usual amount. So you can imagine the implications of that. But not only did we furlough people, we also repurpose people. Suddenly I had, outpatient dietitians who were working as screeners and whatnot, which actually turned out to be a pretty interesting thing. So we redeployed those people. We've since put them back in the regular places. And I like Candy's point. I was really impressed with the revenue cycle team in terms of squeezing money out of places I didn't know there was money to be squeezed out of. Accounts, they really got into some old accounts and got them resolved. One of our great finds in this, and much different from Anil, we let everybody work from home, and I was impressed with the staff. We did it in 3 days, figure out how to get the equipment, all the Wi-Fi, and I really didn't have many people who didn't have connections from home. So the good find there was, everybody thinks they have to print everything. We figured out they don't. Number in their file tracks, they were expected to work every day, and it was often a challenge for them to do it. And so, I can monitor what the follow-up staff is doing in particular. They're now exceeding that by far. And the really good find was we live in a very high-priced area, so to speak. Most of my revenue cycle employees commute more than 30 miles. So this was like getting a raise working from home. They're probably not staying at home, all the time going forward, but they're staying at home some, and it's become a great recruiting and retaining tool that we have remote workers. And again, the work has actually gotten much better. Our IT staff was fabulous at actually, we have something called Jabber to reroute phones to their mobile phones. So, my rule to all the remote workers was nobody should realize or have to do anything differently because you're remote. I mean, you don't have to, it's not a secret. You can tell them you're remote, but it shouldn't be any change in the level of service by being remote. So that has gone very well. And we actually learned a lot of positive things from that.
Great. It's interesting to hear you all talk, and it's like you're dealing with similar things, but the different ways the systems are handling it is kind of interesting. I think it just goes to show that there isn't a right or wrong answer during all of this. It's just figuring out what works the best for your particular facility and being flexible to try something different. So moving on to kind of the next topic, and I'm really interested, as you heard from the bios, we have kind of 3 different size systems and geographically located systems represented on the panel today. Obviously, on everyone's mind this week, we had a historic election on Tuesday that seems to never going to be over. So we can't speak specifically yet to any changes related to a party, but obviously, you know, it's a huge topic not only in our communities and our culture, but obviously in healthcare, because there are very competing differences on both sides of the aisle regarding specifically how they would, you know, handle or affect healthcare moving forward. So, Anil, I'll start with you on this one. Do you have any kind of reflections on this election cycle, where we sit, you know, politically, and what that potential impact could look like for healthcare going into 2021?
Well, I think as an American, we all expect high healthcare and a high level of quality healthcare. So it doesn't matter which party wins. I think we're going to be providing a great healthcare for our citizens. The funding piece is challenging because and it will take a couple of years. So whatever happens is not going to happen on February 1st. It doesn't matter who takes over. So it's going to take 2, 3, 4 years before any significant impact is made on healthcare side anyhow, or the funding of healthcare. Obviously, we all know that one party favors universal healthcare system, and whereas the other party favors free market approach. But whatever happens, I think we as an American demand a great quality healthcare, and I think we're going to continue to provide. Also see opportunity for consolidation, because there may not be resources to pay for all the healthcare for illegals, for instance. If we add 10 million more people to get free healthcare coverage, somebody got to pay for it, and how do you pay for it? So either the benefits will be squeezed for sure. Medicare may start paying at a Medicaid rate or something, but definitely we see a reimbursement side further impacting, which we're already struggling with our reimbursement as is. I think every hospital will say that they're not getting paid enough from Medicare and Medicaid for sure. And if all of a sudden we see a significant increase in that population, our margin is definitely going to be impacted, and there will be further consolidation in the marketplace.
Paul, would you like for me to go next, or would you like to go next?
Go ahead, Candy.
Okay, I was just, I'm going to speak a little less globally on what I kind of think some of the regulatory items are. I can tell you short term, like the here and now, every day this week has been Groundhog Day. We wake up, we turn on the news. Do we have a president yet? We are feeling that in our productivity stats, because my staff is here. They are on site. We are doing more rounds to try and get people away from the water coolers. This isn't an appropriate place to talk about this. We've got people, we have clinicians in the hospital that are discussing politics openly in the hallways. It feels very divided. It feels very divisive. And already we are one of the most heavily regulated industries. Mm-hmm. And depending on whom you contract with, everyone wants things a different way. There is no uniform billing to the Uniform Billing Act that was passed so many years ago I can't even give you the date of it. It was shortly after I left the dental field for hospital. There is nothing uniform about it. I think that the broader politics, regardless of who the president is, it will eventually trickle down to us. I think that it will go very slowly, which I think is not necessarily a bad thing. But even some of the regulations that have come out just in the course of the last 2 years that we've had to shift and be nimble and try and put in place, a lot of them don't make sense. There's too much money surrounding some of the decisions tied in from too many lobbying groups. In my personal opinion, there's too many hands in the pot, and we lose sight of the patient. And so those of us who are active in HFMA and we work at providers, we never lose sight of the patient. So no matter what's asked of us, we always try and keep the patient in the middle, and we always try and follow the spirit of the law. But I can tell you that the divisiveness that I'm seeing present just in the short term, just among my own staff, among my own clinicians, it's not good. I think that it takes the focus off of what we're going to be asked to do. It's a deterrent. We are a very resilient group. We will do whatever is asked. But I do think that there needs to be a bit more coordination. And I think that groups like HFMA, where we have the opportunity to bounce ideas off of our peers so that we can at least get more uniform in our response to some of the changes, I think that's how we impact change, no matter who's in power, no matter who is kind of making the rules that we have to follow. So right now, this week, and hopefully next week it doesn't continue, but my job is to keep people's butts in their seats and noses down so that we can survive not just COVID, but our conversion. So that's kind of how I'm tackling it. I will tell you that not all executives in my organization kind of feel the same way or are tackling it the same way. But I know that that's personally what I can do to kind of make sure that we survive this thing together.
Wow, Candy, I can't tell you how much I appreciate your comments about taking care of our people and kind of keeping them out of the fray and reminding them we came to work today to take care of patients, period. There's nothing else, nothing more important. That code we said would happen, it's happening. It's interesting, and like Anil said, nothing's going to change quickly. My immediate concerns are the capital market, just because I have to think about bonds and those sorts of things, and how does that affect our expansion plans, and can I get to the market quickly enough before interest rates change or things like that. But for the most part, nothing's going to happen fast. And I kind of look back about, we keep talking about we're going to value-based purchasing, and I'm all for that, although it seems like we've been going at a tortoise pace for 10 years. And, in my market, it is fee for service, well, not completely, but 95%. So like y'all said, nothing is going to change, overnight. We have a highly insured market. I don't expect that to change, not anytime soon anyway. So it's really a matter of keeping people calm. We can't change who got elected if we or don't even want to, but that's not our primary thing. Our primary responsibility is taking care of patients and taking care of our employees.
I really like that kind of statement that, at the end of the day, we don't need to lose sight of the patient that we're taking care of and the employees and things like that. And everything is going to continue to swirl around us. But where do we focus as healthcare providers to maintain that goal? So two things that y'all mentioned in this were, the reimbursement continuing to lower. And then, Candy mentioned and referenced how regulated this industry is already. So let's talk about, let's shift our discussion to the price transparency laws that, as we know, the American Hospital Association lost their appeal So as of right now, we have this more highly regulated price transparency law coming, where you're going to have to list your standard charges and your shoppable services starting January 1st, which, as I'm sure the panelists and everyone in the audience knows, a lot of people in the healthcare industry are really concerned about what that's going to do to the reimbursement rates once United Healthcare can go on your website and see that they're paying twice what, the lowest, they're de-identified, but what the lowest payer is paying. So I think we'll start with you, Paul. Kind of what is your facility doing to prepare for the potential price transparency go live on January 1st? And then what sort of additional concerns do you have around releasing that information and its impact on the system as a whole?
We did not use, there are a lot of third-party bolt-on applications to do this. We chose not to do this. We're doing the minimum to comply with the regulations. It won't be the jazziest thing out there. We're the smallest provider in our community, in the Nashville area. We're also the lowest price. So we're not as concerned as some others about people shopping services, because we'll actually win that battle if they do. And, in terms of insurers getting information they didn't have before, I'm not sure they didn't have it before. They're all buying feeds of claims. So it's if they wanted to know, what another payer was getting paid, they could have found that out. So I don't think that's that big a threat from us. What I do expect that we providers are all going to hit up by consultants who have accessed this and want to give advice about it. And that's a welcome thing. So, for us, it's a hassle to do, particularly with so many other competing priorities, but it's not a huge competitive threat for us.
I would say we're taking a blended approach. So we are reliant on a couple of different bolt-on partners that are going to help us do our public-facing URL, so that a patient can really tie into their actual benefits. So if Paul Bolin wants to shop for a new knee at Mon Health Medical Center, he can log in, enter his specific insurance information, and it actually brings back Paul Bolin's out-of-pocket expense, because we really feel like that's the letter of the law for the shoppable services for our patients. And really, that hasn't been as difficult as what we thought that it was going to be. It's primarily off of historic claims data, and then the eligibility response for the patient that includes their benefits, as long as it's provided back. If it's not provided back, it's still, we just run it off of averages. Where we are finding it to be a little bit more challenging, we, like Paul, are not going to have the sleekest, coolest, machine readable CDM out there that lists every payer with every rate by CDM. The majority of our contracts don't reimburse to the CDM level. So we're struggling a little bit with what this looks like, because the law says that you have to publish your CDM and then that rate per payer per CDM, but that's not the way that we're reimbursed. So we're struggling a little bit to kind of translate that piece of the mandate. The shoppable services, that's the easy part. We're testing things now. We're not going to put it out there early. We are also the low price provider in our market. High quality, low price, that's kind of what we always shoot for. We will have the machine readable format out there. It will be the bare minimum. And luckily CMS states that you have to be compliant with the regulation. You have to do it, but there isn't anything in there that says you have to do it well. So you're not going to be penalized if you don't do it well. So the first crack out of the out of the cannon here, I don't know that there's going to be a whole lot of us that do that machine readable file well, if that makes sense, just because we're not reimbursed at the CDM code level.
Well, when I was in South Carolina, Hospital Regional Medical Center, we were trying to get some help from a vendor, third-party vendor, because we needed to update our CDM anyhow, because our CDM has not been updated in several years. So we're trying to find a vendor who can do a CDM review and optimization, but as well as price transparency. The thought process in South Carolina about 2-3 months ago was that maybe we'll pay the fine of $300 per day as opposed to be compliant. It may have changed since I've been out about 6 weeks, but also we were thinking that we will not be the first one to push our charges on. We may wait till see what other hospitals in Columbia or Charleston have done and have a plan, but we were not going to be the first one to comply because there's a significant risk. We already had a significant leakage from our community hospital to other places, and we didn't want to lose any more patients, but it's possible that we could have gained some more. So it's still work in progress for us, but it's definitely a challenging regulation, but it really doesn't matter at the end of the day because not many people really pricing at a CDM level. So it's kind of, Candy says, it's kind of very challenging. And again, another law which goes in effect without a lot of thought process given from a provider side to say what will be the impact on real patient cost. So we'll see how that goes.
Oh, and I don't think that the patient has been kept in the center of this because right now we're all required to publish our CDMs.
Yeah.
But I can tell you that even being in this industry for 20 years, some of your all CDMs are terrible. Like I've been in this for 20 years. You go out there and you start shopping around and pulling up people's CDMs. Yeah, good luck. Good luck. Yeah. And if I can't do it, if I can't get all of the gross charges together to determine how much a service is going to be, your neighbor isn't going to be able to do it either.
Sure.
And so I think we've lost sight of the patient. I think that the spirit of the law is good, but that's got a ways to go. And unfortunately, as hospitals and as healthcare systems and even down into our ambulatory spaces, we're going to be the guinea pigs, and we're going to be the ones that have to shoulder the brunt of the pain on this. And exactly. I think that some of that is misplaced too, because where do all of our claims go and who processes it and who is in control of those contractual terms and how much actually gets passed on to the patient? That's a whole different party altogether than the hospitals. And you specifically mentioned United Healthcare, just as a side note and a comment, just to make sure everybody's awake and still has a sense of humor. I'm not too worried about United Healthcare finding out that they paid double of anybody. Not in my market, at least. Not in my market.
Very good catch.
That's not going to happen. So that was probably a pretty good example to use to not offend anyone.
So, Candy, you talked about, you mentioned the CDM versus shoppable services, and I think that's a really interesting point. The law requires you to have 300 shoppable services on your website, and you have to use the 70 that are provided by CMS, and then you can come up with the rest of yours. I was just curious, have you had any issue coming up with 300? I've talked to some providers, you have not, that they've tried to go vague, and then, then they couldn't come up with enough, and then they went really detailed and it was too many. And
so I will, the way that we came up with this is there are some, and I do have a couple critical access hospitals too. So, when you say 300 shoppable services, they were very intimidated by that. I'm like, look, guys, here's how you're going to do this. You're going to take the top codes or the top services that you get paid DRG by. You're going to translate that into a condition for a patient that they can understand. That becomes, and you're going to do as many of those as you can, because to be able to put the DRG, to be able to post the DRG payment and to be able to do those calculations is likely the easiest. The next area that we went to was outpatient surgeries that we have kind of bundled payments on, because that's the next easiest to do. And then anything that doesn't get you to your 300 from there, then what we looked at was our lab and our radiology, our diagnostics. So it's easy enough to say, okay, so it's these 2 CDM codes for that one procedure. That's how we came up with our shoppable procedures. For Mon Health Medical Center, we actually are going to be posting 380. So and then for the others, we'll make sure that we're at like 303, just so we make sure that we have the minimum. We don't get dinged because we only did 298. And that's kind of how we are approaching this. I can tell you that nobody's CDM is written very patient friendly. So it actually usually has some sort of abbreviation of the CPT code description. So when you start getting in there, it's a laparoscopic cholecystectomy with, fill in all the blanks after that, right? So maybe in our CDMs, it says lap chole. Your neighbor doesn't know that they're having a laparoscopic cholecystectomy. They're having their gallbladder removed. And so now where we're kind of struggling is we've got the CPTs listed in there, we have our procedures listed in there, but they're not real patient friendly. And we haven't found a really good resource for layman terms yet. There is a guide that's published. I won't give any vendor preference here. There's a guide that's published that kind of gives you the layman terms to describe a procedure, but it doesn't take it down to a 2 or 3 word description. It's a paragraph for each CPT code. So we are leaning on our clinical nurse reviewer right now. She's going through our 380 or 300 based on facility and kind of doing a translation for us so that we can plop those in there. And then I think it's really important that you also separate them out by like service code for the patient so that they don't have to look at your entire list of shoppable services. They can kind of narrow it down to, is this a radiology? Is this a surgical procedure? Is this, is this a gynecological procedure? Is this, that way then you can kind of not paralyze our patients with so much data that then they have to scroll through an alphabetical listing to find what they're looking for, if that makes sense. But that's how we're tackling it. We didn't know how else to do it, but it took us a little while to get to that.
Mhm.
And there's a question in the chat regarding post-acute care not having 300 shoppable services. I believe there's an exception in the price transparency regulations for that situation if you do actually fall within an environment where you don't have 300 shoppable services. But I liked what you said, Candy, about starting with the DRGs, moving to the bundled payments, and then moving to lab and diagnostics. That makes a lot of sense to me. I wanted to see if there were any questions or comments from the audience. I know we haven't, there hasn't been anything in the chat, but if anybody has any questions or comments at this point, there's about 10 minutes left. And before I move on to another topic, I wanted to make sure that we didn't have anyone in the audience that wanted to pose a question to the panel.
If they're still awake, I was hoping that we woke them up a little bit.
No questions?
I can't.
All right. Well,
if
you, I know, me either. Either you guys, I think you guys are just that thorough with your answers that everybody has got all the information they need. So we'll finish this out. I'll still watch the chat for questions. But kind of the last thing that I wanted to hit on was the CARES Act and the funding. We're all preparing for the audit surrounding the funding. So it's kind of sort of a multi-pronged question regarding what you're doing to prepare for that audit. Are you finding that you've had a windfall and you have additional funds that you need to figure out something to spend on between now and June of 2021, and sort of how you're approaching this upcoming audit season of your CARES Act funding? So, Anal, can you start us off talking about that?
Sure. As an ex-auditor, I just wanted to make sure that we were really prepared for the audit. So we had a separate cost center set up for anything COVID-related expenses, additional expenses. So we start capturing that information in that cost center. But we also made sure that every month we had all the support, all the invoices, all the purchase order, and ready for an audit. So we just wanted to make sure that we had all the documentation each month in a shared drive. We call it a CARES Act funding drive, and for the audit, because we know we're going to be audited and we want to make sure we're compliant. So That's one thing we really have done that, and we are keeping track on a monthly basis as to do we have windfall, do we have additional cost or whatever. The other thing which I've done is in my current hospital, we gave out COVID appreciation bonus, because our employees have really gone through a lot last 6 to 8 months. They have come to work when in a fear that they may catch COVID, but they continue to come to work. They continue to provide for our patients in a situation where in a housekeeping, for instance, we had a COVID floor, and nobody wanted to go, and housekeeper wanted to go and take care of cleaning the room because they were afraid. And a couple of people stepped up and said, no, we'll go do it. And, they went through the process. So we gave out a COVID appreciation bonus a couple of weeks ago, and it was tiered based on, like, nurses got $7,500 and manager director got $5,000, and every employee got $1,500, and part-time was about half. But it was really went well because it was also a way for us to retain these employees. And so I know that CARES Act provide for that reimbursement. So we felt like that was a good way for us to invest our money in our employees. But I just think that we gotta be very, very careful to make sure every dollar could be audited and could be supported, because we're going to be audited. And the last thing we want to do is 2 years from now have to have a significant amount paid back. So we really have, from a day one, have taken a very strict audit approach and making sure we have all the documentation, and it's saved in a site. So if we lost a controller or somebody else, we don't know where the thing is, where the documentation is. So we really have taken a very proactive approach for the audit.
Yeah, we pretty much did the same thing. And I think the key was from day one, accumulating expenses in a cost center, knowing what the rules were, and being, we had a point person that was their, the main focus of their job during that time was to be sure we did all this in a compliant way. So I think we've done that, much like Anil. I will say hats off to you guys for the employee bonuses. The thing that I'm feeling now, and this is a little off topic, but I can't resist the chance to say it, is, y'all, we cannot express our appreciation of the clinical staff enough. At the beginning of this, I had people bringing in food and, kind of parades around the hospital, and that's all gone away. And these people are still coming to work and risking their lives to take care of patients. And there's just not a big enough thank you for them. So I would say that to everybody in the audience is, we've got to keep appreciating these people. We need them and are very grateful for them. And that's my soapbox.
We've done similar items. We established deals very quickly to track not just the expense, but also the labor expense as well. Anytime that we pulled, Paul mentioned, that's how they kept some folks working, is we pull them to be screeners, and pull them to the front of your ERs to be standing outside waiting on patients when they pull up, to be able to screen them, because in the very beginning we didn't even clinically, we didn't even really know what we were dealing with, right? But there are enough of us that know that with anything that is handed to you, there will be an audit process to make sure that you did what you were supposed to do with it. So, luckily we had some folks there that right from jump, we have been recording those expenses. And then just to tack on to what Paul said about making sure that you are appreciating people. I would also add to that is the burnout, the stress factor. We've mentioned several things that are burning people out. So you have the whole COVID, and then the fear just in people's every day-to-day life. But you have those clinicians that are coming, they're putting their lives on the line to come and take care of patients every day. But then they're going home, and this is impacting everyone. Where it's a constant barrage. You add on top of that the divisiveness with this current election and some of the unprecedented stuff that we're seeing, and then Mon Health system, we decided to even double down on that, and we converted systems too. 2020 has been one of those years where when we all get through this, those of us who are left standing are going to be a little worse for the wear, but I'm going to need us all on New Year's Eve to scream Jumanji so we can kind of reset the clock here. We are seeing some burnout in staff. We're seeing some burnout in leadership. It's not even fatigue alarm or crisis fatigue. It is one continual crisis with additional crises added on top. And so we have to be cognizant of that as leaders, and we have to make sure that we're expressing appreciation, that we're coming across compassionately. Like, I don't think that any of us want to rehash this. The truth of the matter is, it is likely with winter coming and people moving indoors, we are going to relive this again. There is going to be another wave. And so when you have the opportunity to breathe, we need to remind our people to breathe, and that we've all got to take care of each other too. So
It's true.
Well, we're coming up on the hour mark. I just wanted to see, well, first I wanted to express appreciation on behalf of the Georgia chapter of HFMA for our panelists taking time out to participate. We know you all have very, very busy schedules, and we really appreciate you joining and helping us make our virtual institute successful. So thank you. If you guys have any, closing remarks that you would like to make before we close this down, I'm going to open the floor to you right now.
I just want to say I appreciate the opportunity to serve on this panel, and we are really grateful for all our healthcare workers and physicians who are really providing the services for our patients. So thanks to all of the health.
I would add thank you to everybody and thank you for letting me do this. The only thing that could have made this better is if all the people who were participating had a little Brady Bunch bubble. HFMA really is a family. And especially since this is a coordinated effort between Georgia and South Carolina, I got to live that love for a while. So I miss all of you. I miss hugs. I miss us, that human connection of this, because harkening back to the last topic about leader burnout, I think that in large part is what spins lots of our flywheels to know that we're not doing this by ourselves. Oh, Kathy said hugs, Candy, in chat. It's not the same, and it's stinky. It's stinky right now. So hang with it and keep going.
Yeah, I would have to just add to what Candy said. I sure seeing everybody, and it's one thing that we get together and have a drink, but these are our support network, and we talked a lot about leader fatigue and burnout and all that stuff, and y'all are what keeps me going. So it was a pleasure to chat with some folks who are all about the patient, and I'm glad I could be here with you.
Yes.
Awesome. Well, thank you guys so much again. And I think Ariel, is Lawrence online to close out the Institute, or do we switch to a different link?
I don't know if Lawrence is online right now. I think it's probably just me closing it out today. So okay. I want to say thank you everybody for joining us, and thank you for a great panel. Oh, this was wonderful. We're so grateful for everybody, and wish you all well. Hopefully you'll be able to join us for our Spring Institute. That's going to be May 5th through May 7th. That is going to be in beautiful Callaway, and hopefully it will be in person. So if not, be virtual, and that's going to be fine too. But I would just love to see everybody. But thank you guys so much, and have a great day, everyone.
Thanks.
Bye.